Looks like we're reassembled. We'll ask our audience to sit down as we start the roundtable discussion. This is where we go beyond the strict confines of the evidence that we've been discussing all morning and for part of the afternoon, and start talking about the health system, delivery system, and policy, including payment policy, implications of what we've heard to date. How these new interventions might shape the delivery system and what impact it will have. So with that, I have a whole list of questions. I was going to start by asking Lawanda and Dipti to describe the implementation of such programs, but fortunately, we already heard a fair amount about that. Did you have anything else to add to talk about how a hospital or a large clinic would start setting up such a monitoring system for cardiomems or congestive heart failure in general?
So for congestive heart failure in general, there are models that have been in existence for the last 10 or 15 years. The idea is to have a multidisciplinary approach. So we have pharmacists involved, we have occupational therapists who actually do a fair amount of the living with heart failure education. We, of course, have the MDs and the nurse practitioners. And so as I mentioned before, this is an adjunct for our system that's already in place where heart failure nurses were in contact with patients weekly, sometimes daily. And actually what we found, interestingly enough, is that this actually liberates both the heart failure nurses somewhat and the patients, because rather than having to have in-office visits for the really difficult to manage fragile patients, maybe with heart failure and cardiorenal syndrome, they're able to see what the patients are doing hemodynamically, get a set of labs, and say, well, hello, you don't have to come in this week, you can come in next week. So they're actually able to follow more patients more closely and more effectively.
It brings up the question of whether every physician's office, if it's the 30 cardiologists that Dipti interacts with, or all of the cardiologists in a large primary care system like Christine interacts with, or my own facility of Kaiser Permanente. I mean, congestive heart failure patients are managed not only by cardiologists at advanced heart failure kinds of clinics. Does this require a centers of excellence kind of approach?
Well, I think I've already said my bias that it's nice when it's a programmatic approach. I think it's harder when it's individuals doing it because, number one, I would assume individual physicians have a hard time looking at the data on a daily basis and then having a protocol to monitor those patients. So if anything, one of the things that I know even in the post-marketing surveillance study we're going to be doing is that there's a protocol to follow when you look at their PA pressures, and I think that makes it more effective in dealing with those patients. So I think although I'm in a smaller cardiology practice, I think that this is ideally in a programmatic approach, the best way, at least for cardiomems.
So I'm going to ask our payer representatives at the moment what kind of inducements they would consider, or even from a PBM perspective, to make such programs efficacious and use these newer, more expensive agents in the best possible way. And then, of course, we'll open it up to our panel members to ask additional questions. So, Tony?
Yeah. Well, first of all, I think I'd like to talk about some of the impediments to actually even putting a program like this on the ground at all. This kind of harkens back to my Medi-Cal experience. I worked for quite a number of years in terms of a Medi-Cal program as the payer that actually helped to run the program. One of the things that concerns me is that not only does a payer's responsibility revolve around paying for something, it also revolves around making sure there's a reasonable chance that a person can actually receive the service. I think one of the things that hasn't been considered to this point, and one of the things I think is very important, is what's the prevalence of congestive heart failure in, if you will, the underserved population or the Medi-Cal population itself. And I think what you're going to find out is that prevalence is quite high. Certainly, folks that can get their care through university centers, that can get their care through highly developed, well-run programs where there's plenty of resources to do case management, to follow patients. They can get superlative care, but what I'm concerned about is the Central Valley of California, where there aren't the cardiologists, there aren't the case management programs, there aren't the dedicated congestive heart failure nurses to be able to take care of a program like this. Certainly, in terms of giving inducements to these people? How can you induce something? How can you incent something that doesn't exist in the first place, or that has problems existing in the first place? I think it's very important as we consider technology like this, we consider the fact that the technology won't be available to everybody. Are we supposed to offer a differential benefit based on where a patient's located, based on their accessibility to care, based on their ability to pay for care? I think those are very serious concerns. In terms of inducement, I know my plan is very interested in helping our physicians, our clinics, to set up programs that actually support programs like this. But I think fundamental to all of this is that we really have to be thinking about all the population. We should be able to extend this benefit to everybody if we're going to extend this benefit, and to make sure the infrastructure exists, which I'm sorry to say does not.
Well, speaking of underserved populations, George, you have some insight there?
To answer your question about inducement, it takes, and to her point about a organizational approach, it takes an organizational acumen to do what we just talked about in order to get to the success. And so where there is the organizational acumen to do this, as a payer, we would be interested in an inducement. The challenge is we deliver services in a delivery system where there's tremendous variations in practice. We have urban settings where we have very sophisticated delivery models. We have small city, and we have rural areas where that sophistication doesn't exist. We live in a world where we have 80 and 90 style practice that's trying to live in under 2015 rules. That's the reality of our delivery system. And so there's a picture and a voice in my head as I listen to all of you talk. The picture is, as I walk down the ICU setting or a nurse's station, it seems that we are alarm fatigued in many ways. We see alarms go off every 8 seconds or 80 seconds. Whatever that number is, we still do heads down work. And so the question, the voice in my head is, to what extent is that nurse resource a human tap on the shoulder to a provider living in a world that's alarm fatigued? If I can't resolve that, I can't get beyond that point.
Dan.
So just to clarify what the last two speakers said, we have a heterogeneous system. We have an impoverished subsegment that probably won't have access to this. Does this preclude us from doing it where we can do it? I mean, let's say that there are areas within our complicated health delivery system where this technology could be introduced, implemented, and we could learn from it. Or should we say, because we can't give it to everybody, we can't start?
Well, I think it's a consideration that we have to consider, that certainly if we're going to prove the benefit of the CardioMEM system, for instance, and certainly if we're going to prove the efficacy of Entresto and the like, that has to start somewhere, and I agree with that. But the other problem that we have is the offering of a differential benefit. Where Blue Shield is we're into the commercial lines, we're into Medicare lines. We've just entered the Medi-Cal market. And as a policy director, it's part of my responsibility to make sure that whatever service we offer, whatever benefit we're able to give is available as best we can to everybody in the plan.
That sounds like an impediment to me to the introduction of any new technology. If you can't give it to everybody, you can't give it to anybody.
Well, this particular technology is highly, the CardioMEM technology, for instance, where Entresto is probably a different story, but in terms of the CardioMEM technology, it seems to be very dependent on the ability to have nursing staff available to monitor the program. It seems to be very dependent on a cardiologist that has the time daily to check everybody's data and the like. It seems to be very dependent on the ability of the patient to get back and forth to be able to get their medications adjusted, to get the services that they require. It would seem to me, again, to discriminate, if you will, to some degree.
Bob?
Yeah, I'm sorry. It seems to me differential benefit versus differential implementation. I mean, if you're offering it, are you responsible that it didn't get implemented somewhere? How,
I'm going to leave that hanging for a sec because I want to ask Phil a question. Phil, as you can see from his title, is at St. Jude's, and St. Jude's is sponsoring training. I don't know whether you're calling it certification programs. I believe, Wanda, you provide one at USC. You're going to be participating both in the post-marketing study. So with respect to this notion of, center of excellence or the broader categorization of an established, organized program with certain elements, how do you see these devices being used in the general community, and will it happen in the Central Valley 40 miles south of Fresno?
Well, it's a good question, and just to be clear, I have the great benefit to have designed and ran as co-principal investigator the CHAMPION trial and implemented that and then transitioned into the position that I have now. So I'm a heart failure cardiologist. The reality of life is that heart failure patients get differential care. If they live in a small town without a cardiologist, and the nearest cardiologist is 100 miles away, they don't get to see that cardiologist. And so they get a level of care that they couldn't achieve in a disease management program until now. The best model I have thus far to illustrate that is at West Virginia, that has a catchment area of about 500 miles. Very impoverished group of people who can't travel to their heart failure doctor, but they have local doctors that they can contact. It's a unique collaboration between Rob Hull at the University of West Virginia, who implants the device, treats the patient, sends them back home, and remotely monitors their pressure at a level that you couldn't achieve in physical examination, seeing the patient face to face, and has a remarkable effect on patients that otherwise would not receive high-level care for their heart failure. So I think that the infrastructure required thus far has not been extensive. The highest volume implanter thus far has implanted over 60 devices, has one nurse practitioner, one physician who takes about 20 minutes of their day to monitor those patients. Have not had to hire new people or build new buildings or have any other type of new access to technology. So this system, from now I'm speaking as a heart failure doctor, this system makes heart failure management much more efficient and much more generalizable to allow experts to provide expert care to people who otherwise wouldn't receive it.
So I'm interested in not only with CardioMEMS, but even Entresto, an expensive new drug for heart failure. And how does an organization like Express Scripts think about appropriate utilization in an appropriate program with monitoring and modification, step up? How are you thinking about this?
So as it relates to Entresto, at Express Scripts, we administer benefits on behalf of probably 3,500, 4,000 payers and about 85 million people. Since July, we have 750 unique people on Entresto. So we don't see from a standpoint of total numbers, I know it came up earlier in the day, a comment around this idea that people with heart failure, it's as bad a disease as cancer. We spend all of this money per case with someone with certain types of cancer, hundreds of thousands of dollars. Why shouldn't we treat all the people with heart failure the same way? Well, the fact is there's millions of people with heart failure. And if we did, we'd break the bank. As more and more of the cost of health care gets pushed on all of us, we look at this as an ethical issue of the rights of individuals to get access to the care that they need for them, and everyone else to have affordable access to care, period. And if you think about the population as two groups, some people have insurance because insurance means access for them. If they didn't have it, they wouldn't be able to go to the doctor. And then there's many people who it's about preventing financial catastrophe. And so we think about it from a standpoint of, for the people who need access, how do we think about this the right way? So for Entresto, for most of our clients that are in our commercial plans and our Medicare plans, it's a preferred brand. It's at the lower brand out of pocket. Some have co-insurance, some have co-pays. The ones that have co-insurance, some have maximum, some have not. That's roughly 35 million out of the 85 million. We have many customers for whom it's non-formulary, it's brand, it's at the higher copay, and it reflects different philosophies about the populations. I would say that most of the plans have some form of prior authorization, meaning do you meet the criteria that the evidence that's been generated to do that? Some of our customers have step therapy. I would say we generally don't recommend that in our standard plan because we believe that most of the patients coming to Entresto have already been on an ACE inhibitor or an ARB before they're getting Entresto, and I think if you look at the 750 patients for whom we have experience, that would bear that out.
So if you can put aside your fascination with devices for a second, Dipti and Lawanda, so Entresto, you have this new tool as well. How do you introduce it into practice, and what kind of monitoring, considerations, new patients, existing patients, switch, add-on, failures, how do you approach it?
So, so far what we've been doing is switching our class 3 patients. We have a period of washout, which 3 days. It's very clearly delineated. We start the new drug at the lowest dose and we escalate up the same way that we would if we were starting any other vasodilator, to be quite honest.
Yeah, most of our experience so far has been with switching patients that are class 3 or class 4 heart failure patients.
Now, you indicated already, just kind of anecdotally, the intense kind of screening and scrutiny for deciding who should have a CardioMEMS device implanted. What about Entresto?
Yeah, I mean, there is a judgment call. If you think somebody's doing well already, you know, you have to sort of go through mentally, do you want to switch this person? So, and some of it requires them coming back for titration of the drug, and some of these patients have been stable. They may, you know, so I don't know about those patients, but also one of the things is blood pressure. I mean, one of the things that we found out using Entresto is how much their blood pressures really do drop when you put that medication on, a lot more than I would have thought initially. And so there isn't really a lot of room to titrate up as much as I would have liked in some of those patients. And so I do want to bring those patients back. So I think all of those things are on my brain. If somebody's already got really low blood pressure to begin with, I may not be as keen on wanting to switch them over. So some of those things are factors. I'd be curious to hear what her response is too.
Yeah, I haven't seen so much of the hypotension, and it may be because I have a bias to switch over. At least what I'm doing right now is switching over the patients who have blood pressure, to work with, and I haven't switched over anyone who's running a systolic of 100 or 90 or anything sort of similar to the clinical trial. I've been fairly bullish because I sort of talk to the patients, and it's the difference between 1 out of 5 and a 1 out of 6 risk of mortality. And for my, sort of middle-aged patients, that's significant. For some of my octogenarians, they don't care about those odds if they're stable, but it's pretty good odds if you're in the mid of your life.
So I want to ask our panel if there are any thoughts about Entresto coming into the congestive heart failure management programs before we move on.
So can I clarify? This is someone who just came in for a routine visit and you say, oh, there's this new drug that you might do better on, or you just got discharged yet again, do you want to consider going on this new medicine?
If it's a patient who is class 3, then I'm switching, and the patients who are more stable, then I probably am taking a little bit more time to think about them. But in my mind, it's a clear survival benefit, and these are patients who have a very high risk of mortality. So for me, it's very similar to when the beta blockers were introduced. They had not been standard of care. MOCA kind of showed us the way, and then we saw in COMET and in other trials that this was actually a generalizable effect, and then we started using beta blockers. Sort of with every iteration, we saw a higher benefit, but it started off with a fairly low benefit in the sickest patients, and we learned as we move forward. So I don't know, it's heart cancer, and so we have a drug that works better.
I mean, many health systems now could take an approach where they could actually identify these people in advance without waiting for them to come to clinic, and potentially contact them and say, why don't you speak with your cardiologist about this new option? Do you see problems with that, or do you see that's where your system would be going? And maybe they don't even have the capability, but But you could look at people recently hospitalized with heart failure and they had the low ejection fraction, et cetera.
Well, and I would point out that both insurers and PBMs have access to data that could clue those kinds of discussions as well. What do you think?
Yeah, so I would say that we're probably not at the point where we think we should go round everybody up and encourage them to start on this drug. And a lot of it has to do, well, one is there probably is more evidence that we need, right? So I don't think about it like getting someone with heart failure on an ACE inhibitor or a beta blocker for that matter. Because of the multiple trials and other things that were talked about today. At the other hand, we also talked about value earlier, and we talked about $50,000 per year of life saved and quality adjusted life years. This drug is 1,000 times more expensive than an ACE inhibitor, 1,000 times for 20% more benefit. That's a huge difference. So when we talk about what we should be willing to spend, we also have to think about what are the competitive therapies that are already there and how much more is it worth. The reason that it can be 1,000 times more expensive is because we have a health system that the majority of people who have insurance, we have this crazy subsidy that says innovation for innovation's sake as opposed to is it producing as much incremental value as the extra charge that we're being asked to bear. So I look at this as a combination with all the other therapeutic categories, not just heart failure, and for our customers, how are they going to continue to have an affordable benefit for the 85 million people we serve?
Now that should provoke some comment. Others? Rita?
All right, well, I think Glenn raises a really important issue, in which there's certainly been a lot of discussion of everywhere recently because of the astronomical cost of a lot of new drugs and the rising cost of a lot of old drugs, generics as well. But there isn't really any relationship between the health benefits of new drugs and their pricing, and it really seems more like what the market can bear. And for a lot of reasons, our funny insurance system, the lack of negotiation, lack of, a lot of transparency, it's not really a market that operates. And so one certainly could, I think, talk about reference pricing and really looking at the value. And if a new drug, doesn't have more or has a little bit more benefit than an old drug, then the price should be according to its value and not, whatever the company decides to set for it, which it seems to be what happens currently.
Mr. Chair?
We've heard from our payers about the burden of new technology and either paying for a device or paying for a new treatment. I've seen analyses showing the cost of hospitalization for dementia or for heart failure, which is astronomical in both areas with respect to the amount paid for drugs or devices. So if you could reduce the costs of hospitalization by 40 or 50%, you could pay for all of the new drugs at full price. And I just wonder if you could help us with that perspective. You must know what you're paying for the hospitalization for your heart failure patients. Is that, in fact, so much greater than what you're considering paying for these new technologies?
I don't think that anybody has said that the pricing here in terms of, and God bless the manufacturers for trying to get a value, to capture value with their pricing. At the same time, they're not looking at it of how much cost are they taking out of the healthcare system from the payer perspective and the affordability, the benefit, and where is the headroom for being able to pay for that come from. So we saw in the economic analysis that there's benefit in terms of year of life saved, but the dollar value of the hospitalizations avoided is some offset of that price, but it doesn't take, this is not a cost-reducing intervention by using a $4,000 a year drug.
So is there a way you could identify a subset of this population that actually would be cost savings and then really push systematically to get the therapies to them? And I'll ask everybody on the panel to comment there.
So one of the things that's been proposed is similar to the trial, to use basically surrogate markers like BNP, and basically to look at whether or not patients have been appropriately decongested and start off with those patients because there's still room to move. That's debatable, of course.
And a physiologically based approach.
A physiologically based approach.
And I would say, particularly in response to the CardioMEMS heart failure system, the patient population chosen for study was chosen after about 1,000 patient human experimentation to identify what patient population would be the best because we didn't believe that this should be provided for every single heart failure patient, but for those that would have the most benefit, which was the class 3 previously hospitalized patient. And that's, I believe, one of the reasons why the CHAMPION trial was successful. And to iterate on a previous comment, this was the very first time PA pressures were measured regularly. Mm-hmm. All other PA pressure-based trials were a point-in-time right heart catheterization, and we've proven without a shadow of a doubt that a point-in-time evaluation of PA pressures does not impact long-term outcomes in heart failure. It's the reiteration of that and in the right patient population. So, we have actually done the experimentation, purposely identified that. That's why FDA limited its use. And I would say now, not as a heart failure doctor, but as a member of St. Jude Medical, we as a manufacturer would be crazy to try to sell this system into systems that it wouldn't work. We carefully help and implement the CardioMEMS heart failure system into systems that already have disease management programs and that can handle the data. And so it's not just let's choose the patient, but it's also let's choose the center that can be successful with this.
Yeah, that certainly makes sense. Yet I'm still struck by the relative small number of patients who have somehow been additionally clinically screened for initial implantation of CardioMEMS compared to the potential size of all the class 3 heart failure patients. How else can we identify those at most risk, and what criteria would we use to encourage?
Well, and I think that's when you go from having no predicate market or no predicate device, no predicate strategy to a brand new strategy. It's incumbent upon us to make sure we're careful to roll this out, and that's what we've done very carefully. So I think that the idea of 100,000 implants a year is albeit our company would be very ecstatic about that. I think it's not happening, and that's an amazing number of patients that we don't even model in our economic models in the company. So I think there's several ways. I think now that we have big data, now that we have access to electronic medical records, now that health providers know that a heart failure hospitalization costs them $24,000, not the $8,000 that was modeled in the ICER here, but the average being $18,000, ranging up to $25,000. When you say I can prevent 2 or 40% of $24,000 hits, that becomes then an incentive for them to identify patients that might benefit. So I think that's what will happen as we evolve over time.
So you guys have a big incentive. How are you going to find these people?
Okay. Brand new to the company that I'm working for right now, but in prior companies that I've worked for, I know that there was a decided effort to try to identify, if you will, the sickest of the sick of our patients. So the top 1%, the top 0.5%, with respect to utilization of resources, with respect to diagnoses, to identify them and to enter them into active case management. Getting back to the basic question, that technology or that ability does exist or has existed in companies that I've worked for.
So would there be value to consider, particularly with CardioMEMS, a registry so that all patients who get it are entered, and it prevents and that doctors have to report, so that it prevents the opportunity for doctors to choose not to report or not to participate? And then the other question I have is, right now, this data is going into some system that somebody is being obligated to look at. Is there a potential benefit so that the patient gets the result themselves, and then they know what the parameters are, and then they call their doctor? Ooh, I knew that was going to happen.
So two great questions.
Yeah, so I'll answer the second question first. I think, yes, there is an opportunity for further research to get the data into the patient's hands. That has regulatory implications as well as HIPAA implications as how you transmit that data to a patient. But we're actively working to involve the patient in that transmission and have a physician-directed patient self-management approach based on the pressures that are required. you know, the question about registry is a very important one, and we do have a 1,200 patient post-approval study. Post-approval studies are routine after any device approval by the Food and Drug Administration, and this 1,200 patient registry essentially is a little bit more powerful than a registry in that it has outcomes that it will look at. But certainly registries help to understand the patient population being used as well. We get to monitor overall compliance of reading, of looking at website. In de-identified data, we don't know of the patients, but we know how often actually people who implant the device look at the data, and that thus far in the 18 months that we've had this on the market has been remarkably high, in the high 80s, 87% or so. Adherence to looking at the pressures once a week, and the patients are uploading about that same every day. So we're achieving in the real world exactly the same numbers we achieved in the clinical trial, and we're monitoring that as a company, primarily because we're looking for sites that would be appropriate for this concept technology.
I just wanted to be sure I understood
Rita,
you.
just identify yourself.
Oh, Rita Redberg. Did you say that there was a HIPAA restriction on giving patients their own data?
If you send in personalized health information through an email or through a text message, you have to make sure that the person who receives that information is actually the patient for which this information is given. Mm-hmm. And so there are restrictions. They're not insurmountable, but you have to work through those to make sure that you don't get my information by mistake.
So you just need the patient to consent that they understand the risk of an email transmission and that they're okay and that it could go somewhere.
It's a little bit more involved in that from a regulatory perspective. FDA does regulate this very heavily. And
the HIPAA part is the patient can consent to,
correct.
to giving up their rights if they want to.
I had another question.
Oh, go ahead.
Too. Rita Redberg again. How many patients have been implanted in the last 18 months with CardioMEMS?
Well, that number is actually proprietary, and so unfortunately it does impact a lot of different things that I am not at a level to impact. I will say that it is remarkably lower than what the projections have been in the ICER assessment of overall budgetary here. It is right according to our projections as a company. But is certainly like 1%, I believe, of what has been suggested.
I will just use a little sterile needle here, Phil, to say that, you know, your other speaker talked about looking at sales volume. We actually did ask the company exactly for that data and was told it was proprietary. So we didn't have the company estimates
I didn't
to go
know
by.
that. I was
You can reverse
reason
engineer it based on the revenues that we say, but I don't want to get fired.
The reason I was asking is because I'm interested in the registry and how you were, you know, if it was, say, over 1,200, how would those 1,200 be selected, and then would the registry results be publicly available so that clinicians could look at those results?
Sure, absolutely, and that's the intent, is to monitor a real-world application of this concept since it's new. As we go along, there'll be a lot of predetermined subgroup analyses and studies, gender being one of them, overall outcomes, sites and compliance. So we've so far implanted or enrolled about 180 patients in that trial. We are going to have up to 150 centers that'll be involved in the post-approval study. And those centers have to qualify by at least having some research infrastructure, but also have some experience in monitoring patients with heart failure. So again, the centers that we have targeted for, we haven't targeted, but they have come to us and said we would like the CardioMEMS system. Then we evaluate their needs in terms of disease management, help them set up a disease management program if they don't have one before they start implanting. And that's part of our educational process, both to educate the provider as well as the nurses and the implanters.
So I just want to come back to the general question we started with going down, which is there the ability to identify those patients who you really want to get these therapies to, because they might actually be not only beneficial to the patient, but cost-saving to the system. And Wanda said, you know, clinical selection factors are involved. Tony said data exists, though it's hard to apply. Glenn, can you figure out some way to, is this your step therapy or a prior approval process?
I think the way to think about this is the promise of analyzing big data, and it's the promise of personalized medicine. And if someone has a predictive model for who should get Entresto, I'm happy to look at it, as well as, I suspect and believe strongly that there are opportunities going forward, both from a standpoint of data that gets collected today, as well as there may be some other things that we need to know about those individuals, whether it's their genetics or other parameters that are unique to them that are going to be part of what makes a predictive model work.
Now, I know you give advice to all of your clients, and you don't just accept their coverage policies, de facto. What kind of evidence would induce you to tell them you should put this drug on first tier, and this broad population should be getting it?
So for the formularies where we have an independent P&T committee that manage, and those are mostly for our plans that are national in nature, we did evaluation that looked at both the evidence for the drug, as well as pricing for the drug. And while I can't speak to the specifics of the pricing that we were able to negotiate, it made sense for our customers to have the drug in the preferred tier, given our predictions about utilization and the price that they could get for doing that.
Thank you. George, can you identify a subset of your covered members who would benefit, and how would you design your programs to encourage them to get these therapies and monitor?
So just a quick word about our population. Our population are folks with advanced age, different than the population that was studied, the mean age population. Our population is in the high 70s. We have a population with many co-occurring or comorbidity conditions. We have a population with fixed income. We have a population who have conditions that many of them are on over-the-counter NSAIDs, for example. So those are considerations in how we designed this. Now, there is a clinical trajectory and a cost trajectory to this population, but getting at the information such as those co-conditions, the folks on NSAIDs, that's a much harder thing to do. And so what would help is some additional information on the long-term safety profile of the drug. A second piece of information is the cost avoidance for hospitalization in a population like ours or anyone else's population. That allows us to map out that clinical and cost trajectory.
And Dipti, can you help abstract and crystallize those elements of clinical judgment that led you and your colleagues to select certain patients for CardioMEMS now, and the patients you're going to switch to Entresto?
We've learned a little bit about the CardioMEMS patients, which is that initially we were trying to, this notion of the sickest, figuring out who are the sickest patients, but sometimes those aren't always necessarily the best patients. So I would say that we had one patient that already passed away, about 2 months after their CardioMEMS, and probably was a little too late in the game, so they maybe were too sick at that point. So maybe the best benefit is to somebody that's maybe not quite as sick as that patient was, and maybe you want to even get them earlier so that you can improve their quality of life. And that, unfortunately, the device wasn't approved, wasn't around for that. So I do think that patients that are on optimal medical management, that are having recurrent hospitalizations in spite of, your best, those are probably the best patients to try to see if you can impact it, because you want that objective data for the disease management piece of it, because otherwise, like I said, you just have interaction, but that's not meaningful interaction. I think that if somebody comes in with class 3 heart failure, I think Entresto would be something that I would think about starting them, initiating that if they were new, rather than starting them on an ACE inhibitor initially or an ARB. I think that the patients I see in the office, there's lots of variables that go into it. I think about the economic impact on those patients. I think about, I think about how they're doing, how sick they are. I mean, lots of different factors that go into making that decision. But I would certainly, at least in my own mind, think about every one of those patients and know why I did or did not choose that, switching those patients.
Other thoughts about what we're discussing here?
So this reminds me a little, the CardioMEMS thing reminds me a little bit about our DBS patients, what we're implanting with a device, and it's really all about...
Tell everybody what DBS is.
Oh, deep brain stimulation for Parkinson's disease, and really is all about patient selection. You get them too late, they don't benefit. If they have dementia, they don't benefit. If they don't get a response to medicine, they don't benefit. And it really is all about patient selection. And I think that it seems to me that when you're selecting these people, that's going to be key. What the criteria is. We have a panel that goes through to do a selection, because I don't think I'd want to do it on my own. And we also have a wraparound program to do the monitoring. So I think that it really ought to be thought of as one part of one component of a system. But I think maybe as I'm looking at this and reflecting, I think the secret sauce here may be the fact that we are still managing chronic conditions in episodic office visits. That's largely the model for managing diseases. And maybe what's happening here is this allows you to, manage your chronic condition population in a much more continuous fashion. So it just kind of strikes me that I've seen this all before and we're involved in it, and what seems to be the most successful is careful patient selection, group decision on it, and only doing it with the wraparound program. And I think that ought to be kind of the focus rather than the device itself. And you probably want to discourage, cowboys out there implanting without the support.
Well, it does look something like a lasso, actually.
So we went through, I put the first implantable hemodynamic monitoring system in a human being in 1998. And so it's been since that time that we've dealt with this concept, and we have found that Class 2 patients that are predominantly Class 2 are too well. Their event rates are so low that you can't, if your goal is to prevent hospitalizations, you're not going to prevent hospitalizations. And as been said, we've also studied Class 4 patients, stage D refractory Class 4 patients who are so symptomatic that even when you know those pressures, you can't keep them out of the hospital. In fact, one trial suggested we might even put them in the hospital more often when we knew their data. And so the very fact that we have already gone through all of that human experimentation since 1998 and found the group that's most likely to benefit allows us to have an evidence base to move out into the market and say, this is the patient, this is the patient. That patient's not the right patient. This is the right patient. And I think that's one of the good things about Champion.
So, Paul, you actually brought up the notion of proactive population management, and we're hearing a little bit more about predictive. What do you think?
Yeah, well, now I'm going to maybe go against that and just say that I think there's well, we want to identify the best patients. I don't think we have knowledge beyond the clinical trials. An analogy was, say, the cardiac resynchronization therapy for heart failure, where initially everyone thought, even though this wasn't measured in the trials, if we could actually see what their synchrony was to begin with, we could find who was going to benefit, who wasn't it. We could further restrict. We could do a much better job. And in the end, I think they realized, listen, that didn't work. We need to go with what data we have from the clinical trials, and if certain patients benefit within the trials, we can use that. But I think I'm concerned it gives us a false promise of big data that we can find all this detail about the patient and make a better decision than we had, say, from 500 patients in the trial. And I think you're always going to be limited by those 500. Now, fortunately, we know enough from that, but I think it will be very challenging to go beyond that and say, okay, I can ignore these people that were in the trial. They probably didn't benefit, and we should give it to this group. I think it's going to be a real challenge to use the data to improve care.
Can I make a comment?
Yeah.
One other thing that what we've tried to do is, palliative care, and Alex, you'll appreciate this comment, almost every patient that comes in, we try to sort of talk about palliative care and at least try to do a palliative care consult. Unfortunately, even the term palliative care is sort of a turnoff because patients don't like that. Somehow they equate that with end-of-life care, and they don't. And so one of the things that we're trying to do is if we have a CardioMEMS patient, for example, we say that I forget the terminology we're using, but we have a term that's different than palliative care that we're saying is part of what they're going to have to go through as doing all of this, so that we're sort of introducing that concept. And we've had at least one patient that has had a lot of intensive monitoring and intervention and is just not doing well. And so now the family is completely agreeable to moving forward with other aspects of that, which they weren't amenable before, because they feel like we've actually done all this stuff, and they can also see because they see how the patient is doing. So that has actually helped the case in terms of palliative care.
Yeah, I like that. I mean, one of my concerns about putting in these devices is, clinically I practice palliative care, and a lot of what I do is stop monitoring patients, stop the ICD, stop the blood pressure monitoring. So putting another monitoring device into somebody is another thing that will have to be stopped. So I laud you for having these conversations. I mean, there's nothing to stop, but you would just stop monitoring. But that in and of itself is a conversation that would need to happen at some point. And it's important to set people up who have this chronic fatal condition for those conversations later on. So I'm glad to hear that introducing the idea of palliative care, supportive care, early on as part of the package, as a trigger when it comes time to implant one of these devices, is something that's on the radar.
I just have a question about patient selection.
I'm reminded to everybody identify themselves. Tony?
Oh, I'm sorry. It's Tony Van Gore here. I just have a question about patient selection. When we're talking about patient selection, are we only talking about the physiologic parameters that would cause you to select a patient, or are there other parameters that we should be considering and should be discussing? The patient's ability to understand the therapy, the patient's ability to execute the therapy, the patient's ability to access care, to use the internet, to use the phone, to connect with the nurses and the like.
This is Phil Adamson. Again, absolutely. And we did that in the clinical trial. The good news is that the extent of the operational portion of obtaining information from the CardioMEMS system is the patient lies down and presses a button, and that's it. And we did an analysis in patients over the age of 65, and they actually had a higher compliance to daily uploads than those that were less than 65. So the age of the patient didn't matter. But if a patient is demented, if a patient has other comorbidities that are going to limit their life, all of the things that one would go into for any kind of device therapy, I think are operant here, including an assessment of the patient's ability to interact with the system, albeit the system is incredibly simple, and so far we've not found a whole lot of people who couldn't do it. But yeah, that has to, I think that goes in, if you ask the physicians here, I think that's part of the process of providing any therapy for patients who have a chronic disease is can they take the pill? I mean, can you take are they going to be able to take Entresto or be able to, comply with any of the things we ask them to do?
Barry?
At some point during the afternoon, I wish I could hear some discussion from the panel or any of us. We seem to operate within the assumption that the price is what it is. And so now we're going to have to figure out how we work within that arrangement. And by with the formula that we've set up, and I've heard what we've said about no particular ceiling and so forth, but nevertheless, both of the things we've talked about today look like they would add a pretty significant burden eventually, depending on the uptake. So probably not a fair question to ask the representative from the manufacturer, but how do we move to that other kind of question, which is a more rational approach to the subject of price?
Well, I will not pretend to understand what drives market pricing, being a cardiologist, although I will say that traditionally healthcare costs have been considered effective or not effective or good or not good based on healthcare economic evaluations with incremental cost effectiveness ratios per quality of life saved. So we have a standard, we have a benchmark, which has traditionally been how much it costs to dialyze a patient in 1970, which is $50,000 per quality adjusted life year saved. Thank goodness now that's adjusted more to what today's healthcare costs are, which as the people at CTAF and ICER have put at $150,000, which I think is pretty reasonable. In the budgetary analysis, in particular for this device, if one assumes 14 or 15,000 or 100,000 implants a year, the cost of the system is immense. We would never see that kind of, and that assumption alone makes the incremental cost effectiveness ratio and how much it affects the budget dramatically different. And so if we say, okay, there's going to be 8,000 or 10,000 implants a year instead of 110,000, then the price to be economically viable could be up to $30,000 per unit, which is double the asking cost of the device. So it's all in the assumptions of what we've traditionally used in terms of healthcare economics, and all of those things go into the process. Research and development costs a lot of money. Innovation is expensive. And in particular, this system in which we pay cell phone costs and follow up for the rest of the patient's life without a further reimbursement is one that you have to kind of factor that into the initial cost of the system. So there's a lot of stuff that goes into that, and I think it is negotiable, but I think it is certainly something that that requires a thoughtful evaluation, and our traditional way to do that is with ICER evaluation.
I can't speak to devices, but I can speak to drugs. And our experience is that manufacturers price to the value they think they can extract from the market. It's not a basis of what the particular drugs cost them to manufacture or cost them to develop, but in a subsidized environment where people don't pay the full dollar cost of their medications, where now we have with the Affordable Care Act a cap on out-of-pocket costs for patients, where manufacturers, through copay assistance and other programs that are illegal in Medicaid and illegal in Medicare, they can shield the patient from the true costs of those drugs. They go for what they can get. And I can't say that I blame them given our system, but part of how we see pricing as being particularly unfair is if you look at other developed countries around the world, why are prescription drug prices twice as much as they are here? You have different cultural systems.
The other way around.
Right? I mean, well, they're half as much, I'm sorry, twice as much as they are, twice as much here as there. And they have different cultural systems where the government will make a decision for that the population in general agrees with, that this is what we can afford. Here, we want everything for everybody, and we need a different way to be able to think about it. It's also part of why I don't have confidence that a government solution or a government negotiating with the manufacturer is going to work, because we are so political, and every small group, every special interest group, right, has some clout. And I just looked to our own Medicare program as an example where there are drug classes that are protected classes, number of drugs that need to be covered, where in commercial plans we're able to use cost management techniques that are quite different. We never could have done what we did to bring down the price of the hepatitis drugs, as an example, if we only could have done it or had to work with the Medicare plan.
So we're going to talk a little bit more about financial mechanisms. Actually, I'm curious, at Hoag and USC, are you obtaining devices through a GPO, a group purchase organization, or individual contracts? Who does your contract negotiations for you?
Individual contracts.
Do you get involved?
Yes. And basically, there are some insurance plans that have paid for the device because they see a value in reducing hospitalization, and sometimes what we have to do is explain what our rationale is, and essentially on a patient-by-patient basis. And the types of discriminants that go into that conversation are the risk status of the patient, their previous hospitalization record, how sort of compliant they've been demonstrated to be in the past, because that is a question, whether or not the patient can comply with the utilization of the device. And so for our patients, having been in a program where they were doing daily weights and maybe, sort of calling someone and had some involvement is an important test to be able to say that this is a patient who can benefit from a step up in care.
Did you negotiate, be part of the
No.
business negotiations?
No. I think there's a system purchasing program, but no, they ask the physicians for sort of this type of thing, what's the use for it, how useful it is and all that. But in terms of the actual negotiating the price, the physicians are not involved with that.
Yeah, Glenn, I think
I'm
you have
just
a
going to
market
say
here.
something from our data. I'm going to use examples from high blood pressure, depression, and oral diabetes medications. A third to half the time that a doctor either increases the dose or changes from one medication to another, the patient has been previously non-adherent. And when you ask your patients, are you taking your medicine, we all know it's socially unacceptable to admit to your doctor you're not doing what they told you to do, and they say yes. So that if you look at the refill patterns, and I think that's part of in thinking about any new and particularly expensive therapies, what has the patient been doing up to that point, and why is this going to make a difference for them?
You think doubling the dose when you're not taking it helps?
Yes.
But you have more pills accumulating in your drug cabinet at home. So we talked about contracting, and I want to get this issue on the table of, are there ways to have more kind of performance-based contracting provisions, not just discounts based on volume or moving market share or something else? And Glenn, you told me you've had some experience about this, have some points of view about performance-based, some people call them risk-sharing agreements, and in this case would likely be based on avoidance of hospitalization with both of these interventions.
So actually it was in the pre-reading that was provided, one of the things that I thought was missing was the fact that if 10 to 20% of the patients on Entresto never get to a point where they can tolerate and continue on it, why is the drug full price during that period?
How would an insurer, what kind of policies do you have for dispensing such agents when they're being up-titrated?
Yeah. Based on, or the question concerning performance-based contracting and the like, I know that that is something that we haven't tested yet in Blue Shield, and that's something that we're looking at. Certainly, I believe it's best to say there's a number of management challenges that are involved in that, but the plan is open to exploring that systematically. What sorts of risk sharing should the manufacturer have if a device fails or if hospitalizations continue at a rate that's very high? We're looking at it, but we haven't adapted to policy yet.
How about for SCAN?
Whatever we do, we need administrative simplicity. If every time we do something with one manufacturer or whatever, I have to hire someone to manage that, cost will outpace whatever savings there are.
How do you try to save your hospital money, Dipti, in the management of this population, particularly when you're taking away, heads and beds?
Well, I mean, I think that's where the appropriate patient selection comes in. That's why the education about what the appropriate patient selection is and having protocols for all of that so that we can give feedback. And sometimes when they want to do something, say, no, this is not an appropriate patient, and there's interaction. If the reason I want a programmatic approach even for CardioMEMS is so that if the device is implanted, that the physicians are actually acting on the data that's being provided, because otherwise that's not really helpful.
There is one clinical question, Lawanda. In your program, you have access to all of the data from all these patients, and you don't have to say, please, may I, like Dipti had to?
So we're a little bit different in that we're a team-based program. We actually also implant for some of the private practice physicians, but kind of as a requirement to be implanted through our program, we see the data. And so we've presented it as a value added, because there's an extra set of eyes looking at the data, and I don't know, but maybe they're a friendlier group, but they've been at least amenable to having our NPs look at the data and help. And we have patients as far out as Bakersfield who this has been a tremendous asset to, because we can call and manage their heart failure, and they don't have to come for visits once a month.
I was just curious about the little difference between the more community setting and the academic setting.
But what we're seeing is that as a physician implants more, they actually appreciate the help from the nurse practitioner. So they're actually more amenable to saying, yes, they can look at the data. So, I mean, I think that's going to be less of a problem in the long run.
So would St. Jude's be interested in discussing some sort of performance-based contracting?
Well, I think there have been discussions about that, and as has been mentioned, the administrative, how you administrate such an agreement is unique. Certainly for this system, we are able to track to see if the system is actually used properly, because from a manufacturer's perspective, if you implant it just because you can and then you don't look at it and, oh, by the way, we didn't see a reduction in hospitalizations, it isn't because the sensor failed or the sensor didn't work. So we and all systems are able to track adherence to looking at pressures, and so yes, we've had preliminary discussions through our process to add that to contracting.
Panel comments on such a thing?
Can I point out, or can I just throw out something here? We keep going back to this, and not to pick on the CardioMEMS, because I think the Entresto actually deserves some voice time here too. You know, in the first place, I come from the world of oncology, where we're used to the six-figure crap that is way just insane. So these things are cheap, okay? I mean, they just are. It's kind of hard to get your head around talking like that. When we graduate to the reality of the usage, then we start talking about a little hallway snippet that I heard earlier at lunch, was that CardioMEMS is not actually being marketed exclusively to treatment centers, where the patients are really going to get their ongoing care. There are specialists that are doing the implantation, and then the patient actually lives somewhere else. And the first paragraph in our report here actually points out that CHF is not a disease itself. It's a condition it's where the patient ends up as a result of any number of other things. So the patient is not in primary care anymore. We're not talking about pushing something anywhere near that level of the system here. We need a specialist care system. This is the thing we've gone round and round with 2 or 3 of our things. The patient needs to go. The patient for this particular service, this particular indication, needs to be in specialist care, a center where we actually really do this all the time. So to keep having this center issue, the word come up all the time, is a real big thing because the center doesn't exist for most patients, and we're not coming anywhere near it. It's a real bugaboo. I don't have a wonderful little
but what about
closing
Entresto?
thing to.
You started on Entresto.
Well, no, but this is the deal. The cardiomems, if we're doing this right, is going to be actually implanted in the right place and followed by the right people. Any one of these people this guy can write me a script for Entresto right now.
I'm sure he can.
And, you know, that's been thrown out, not exactly in the wild blue yonder here, but, you know, Jeff actually talked about the Cowboys, that, you know, he's concerned about the Cowboy getting loose with the cardiomems thing. Who the hell knows where you go with Entresto? You know, if it's really, if you decide you can have a moneymaker idea here because you're going to do something that the CHF specialists aren't really going to do to you, because they're going to go back to the old-fashioned things first. And what is the ramp up here with all of this? I mean, does Entresto come before cardiomems?
Well, I think that's a really interesting
and
question.
How did we get there in the first place? And who really is at the start of the system here?
So. Yeah. So, Christine, are your primary care doctors going to be prescribing Entresto instead of enalapril?
I don't know. But that is true. You know, you know, with the cardiomems, you have to at least be trained in order to implant this, and presumably that's going to happen in something with some more infrastructure around it than, you know, a community hospital in Podunk. But you're right, you know, any physician can prescribe any medication to any patient. And that is obviously one of the concerns, is that once, in particular, medication is out there, that then we start to lose the oversight over who gets it. And that's where, you know, what Glenn was talking about, it becomes important, is, you know, how do we know who should have it? Should it be step therapy? Should it not be? You know, should the tiering can help drive some of that. But I think there's some question even between our two cardiology experts as to the approach in a class 2 patient. You know, is this something you're going right to? Is it not? There's enough question, and we have question as to whether it's really efficacious. So, and I think the other aspect that's been brought up a couple of times is that there hasn't been anything new in heart failure in a long time. We've actually been in a period of, which is happening with a lot of medications, sort of a false sense of security around pharmacy drugs, where many of the medications we're using have been generic for a long time. Lipid medication, heart failure medication, blood pressure medication, and that's starting to go away. And it's going to have a huge impact on the healthcare system over the next few years that I think, I'm sure you guys are already scared of. We're starting to realize how this is going to impact things. And then what do we do? How do we educate our frontline docs as to what is the proper place for these medications in the course of treatment and given the overall armamentarium? And I think we don't really quite know yet.
So I just want to add a comment to that. We're very interested in how the technology diffuses throughout all the practitioners out there, right? So there's probably about 1 million people in the United States, plus or minus, who are writing prescriptions. And so for Entresto, as an example, we require as part of our coverage policies that it be started with and managed by a cardiologist. That's an example.
Just to emphasize Chris's point, this morning the Healthcare Cost Institute published a report saying that in privately insured populations, the cost of brand drugs has gone up from 2013 to 2014 by $45 per person in the entire pool of privately insured people. Most of that driven by one agent for one condition. which gets us thinking about how do we have, I think you used the word headroom, to absorb all these things, not just for hepatitis, but for congestive heart failure and Parkinson's and multiple sclerosis and asthma and diabetes and all of these things at once, which just reinforces the gravity of Jerry's question. So any other comments or thoughts from the panelists about these kind of performance-based contracts and whether they're worth pursuing?
I think it's very difficult to decide whether performance was as expected when you have a chronic disease like this. Maybe you have a patient who died in 3 months, but maybe they would have died in 1 month if they didn't get the condition. So I think for these chronic conditions, very difficult to actually put any metric in place.
Jeff?
Whenever I hear performance-based, I think a lot more paperwork and work for the doctor. So just be aware that, I mean, you know, there's a huge amount of stuff that gets piled on that doesn't actually necessarily add patient values. If you're going to do something like that, it can't be on the back of the practicing physician or it will fail. And so just because it's an easy thing to say, but it's a hard thing to implement in a busy practice.
I was actually hoping we'd, oh, go ahead, Kim.
And I think that that's where the registry and the patient selection becomes important, because if it is performance-based, then the doctor will just pick the people who will make him look good. And so
Yeah, so some things that, you know, when we've been approached with these kinds of arrangements previously, if it's hospitalizations, is it all-cause hospitalizations? Is it only the first ICD-9, now ICD-10 code that's listed as the primary diagnosis? You know, it has to be simple.
I was actually, go ahead.
Yeah, I think something was also said earlier about we're kind of doing episodic management of chronic conditions, and I think some of these different models are trying to get to that. And on the one hand, we have an increasing number of little gizmos that'll transmit data on an ongoing basis about what physiologically is happening to a patient, and you know, you could imagine just, you know, a physician being flooded by numbers on their patient, and you know, without algorithms and structure to filter the data in an appropriate way and give those alerts. I think that's where we need to go with how do we set up systems of healthcare that are more continuous and are less episodic, and that really allow us to deliver care to patients where they're living all the time, instead of the model that we have. And I think that if we figure that out, that'll kind of rocket past a lot of these discussions. Should it be an ACO or an HMO or value-based or a, you know, what other kind of model we have, and that we're actually going to give care in a different way. This is kind of a step there, and I think what we're struggling with is what should that infrastructure really look like? What will the delivery system look like in 10 years?
Right, it's a really fascinating point. If we look at the analogy of anticoagulation clinics and INR monitoring, the more often you measure, the more often you have a result to respond to, and the more variation you might see just from random processes. And in a VA study, they actually looked at this and said there's this phenomenon of tampering when you're monitoring physiologic processes, and you might start, you know, treating, and then you get the wider swings. So Phil or Lawanda or Dipti, how do you actually say this is an elevated pressure reading that I need to respond to, or this is now a trend that I need to respond to, and not just a one-off thing?
Part of it is knowing. Lawanda Grisette. Part of it is actually having knowledge of the patient and following the trends. So one of the things that we do with the initial implantation is that we do a full right heart cath where we know what their output and their index is and sort of their optimal operating conditions. And then we use that as a benchmark. And we do see these patients from time to time as necessary, and so we're able to gauge whether the trend is heading in the wrong direction, and we make adjustments. Part of the benefit of having this system is that you can see the effect of the adjustment in near real time. And so if your first instinct is to use a vasodilator and you don't see a change, and you think, well, now maybe this is volume, then you use a diuretic and you see whether or not you see a change. So there's an iterative part to this.
Well, and this is the key to the success of any kind of monitoring system is, are we producing data overload? Are we producing actionable information that can now allow a more efficient means to continuously manage a chronic disease? And heart failure is a perfect example because it has all the other comorbidities we've discussed. And if one allows one or two of those components to get out of control, the patient's in the hospital. So in the trial, we actually set goals for pressures. We gave an algorithm of choices of medications to choose from in terms of getting those pressures to goals, which initially was an intensification of diuretics and then addition of vasodilator therapy. But the absolute overriding concept here was that this was true personalization of medical care delivery to that individual. And so the physician had to understand what was the natural variability of the patient's pressures, what represented a trend. We asked the patients to upload daily to create a trend analysis, not necessarily that doctor had to look at it every day, but they could populate a trend analysis because we learned that pressures go up when patients get sick, and they start to go up 3 weeks before they start to get symptoms. And so when we learned that, then we were able to inform the investigators in the CHAMPION trial and now the users of this system. A trend represents a 4 to 5 millimeter mercury change over a period of about 5 days, and you better start to act on that. And that kind of processing becomes much more intuitive after you've done it a couple of times.
No, I agree. I think that we have an algorithm that we use, and I think that's very helpful. But we do get baseline at the time of implantation and then utilize the numbers on a patient to sort of follow it and try to use the algorithm to sort of guide therapy.
Any other questions or thoughts from the panel?
I'm not sure whether this has come up. Have you seen with the patients with the CardioMEMS device that it's helping them behave appropriately? For instance, if last time I ate a hot dog, I got a phone call the next day from the nurse, maybe I don't eat the hot dog next time. I mean, are you seeing that kind of behavior change in the patients over time?
I'm sure that there's a lot of anecdotes, but yes. And in fact, we've seen people sort of personalize or humanize their system. They name it. Mm-hmm. And they say, Pam is really mad at me today because I had Chinese food last night. I bet you I'm going to get a call. FDA was concerned at one point to give the patient their own data because they felt like the patients would push themselves to a wall and then stop if they knew their pressures. Quite frankly, if you've ever taken care of a heart failure patient, they do that now. But they have very inaccurate and imprecise data like a daily weight that has a 9% predictive value for predicting a hospitalization. So when we're able to give them some life back, their quality of life improves, and they realize what compliance means and how. And I don't know about you, but when I was in practice, I would bring my patient to the computer screen and I'd show them their pressures. So what happened here? And they'd say, oh, yeah, well, I want to go to church, so I didn't take my diuretic, and then we had chicken for the church dinner. And they could see their pressures go up, and now they understand completely what that behavior will do. So it has been, in many patients, not every patient, it's not going to make a devil into an angel, but it certainly does allow for patients to have some feedback about their disease process.
Okay, we have Dan and then Kim.
This is way out in left field, but I'm curious, since we have these devices in outpatients with heart failure, what is the daily profile? I mean, the diurnal variation, I'm sure you must have that. It would be fascinating to me. Is it right after a meal it goes up, when they're sleeping it goes down, and with that profile, is there an optimal time during the day to take the measurement?
So we've done a tremendous amount of research into that, as you can imagine, and the first implantable hemodynamic monitor did measure 24/7, 365, and so we were able to see diurnal variation within the day. We saw weekly variation. We saw biweekly variations that were predictable. When one did frequency analyses for periodic events, you could tease out events that occurred when the moon was. I mean, you could almost prove anything. So you had to be careful about that. But on the other hand, what we tried also to understand is what is the minimum amount of time, and when should you measure this pressure if it's going to represent a 24-hour period of time. And we found in the morning, after the patients awaken and get up and around and go to the restroom, they lie back on the pillow, and that we proved to be as good as if you put in a Swan-Ganz catheter right now, you would get that number. So you can imagine if you measured it regularly, if patients were more active, less active, up, down. So we supine in the morning after they've used the restroom. That is the best predictor of what their pressures are for the entire day.
Kim.
I didn't mean anything, but when you made the comment about the eating the hot dog, it made me think back about the unmeasured confounders, that being able to feed iteratively back to the patient probably is a positive that the nurse communications helps reinforce.
It's a great educational moment for the patient, and you have to. I think if you want to drill down to what was the mechanism of the success of the Champion trial, it was because we knew where the pressure should be. We actively treated them to get them there. All the other things that went into that was that we were able to really now provide the patient with a total educational package about their disease. It's their disease. Now they can own it, and eventually we'll have the pressures in their hands, and they'll be managing themselves.
Well, with that, I'd like everybody to thank our expert roundtable participants. Thank you very much for sharing your expertise and your experience and your thoughts. And we'll ask you to stand down while the panel reflects on the day. Okay, whatever you're most comfortable with. So at this point, we'd like to do our usual reflection from the CTAF panel over the evidence discussions, the value discussions, health system provisional value discussions, and the broader discussion that we had from our experts on the roundtable. And this is your time to reflect and project. So Kim, we're going to go around.
Wow. I will say that this was I really appreciate the roundtable discussion and actually the patient visitor. Having read this twice, it actually gave a different, better perspective, being able to participate with everyone.
Thank you.
What made it difficult for me, I think, was that we were dealing with single trials, primarily for the CardioMEMS, given the size, and that how do we weight a single, even the very, very strong positive effect, how does one weigh the fact that it was one setting or one study?
Sure.
I just want to come back to the question about the economic realities, and I want to say a word of appreciation to Dr. Stettin for raising the question of fairness, because if what makes something like CardioMEMS acceptable for the overall cost of the system, the low uptake, then you have to ask, well, what about if it's as great as it's supposed to be? What about all the people who needed it, who didn't get it in that case? You're sort of hoping that not those people will not get it because its acceptability in terms of the cost of the system depends on their not getting it. So I hope we'll keep thinking about how we can speak with some elevated degree of discourse about the relationship of fairness to the cost.
Thank you. Rita.
I thought we had a very good discussion. I thought the evidence reviews were excellent. I, too, share the concern that we really don't have the evidence that I think we need to make really informed choices, that, there were a lot of problems with the single trials that we looked at, and that, in the big picture, we have the most expensive healthcare system in the world by far. We have far from the best outcomes, and and sure, you can make these incremental, cost-effective, analyses for quality-adjusted life here based on suboptimal data, but the truth is that we use way more of this, and a lot of it inappropriately in the U.S., and that we're not really getting to that issue with every little incremental. I mean, and that's why I think the new analysis of the budget impact is really important, and it does get to a fairness question, because we're all paying for this, and it's clear that Medicare and private insurance are getting to unsustainable afforded rates. We still have high levels of uninsured in the U.S., and it relates to what we're spending on healthcare and what are we getting for it. And I think we're really trying to look more closely at it, but it certainly, to me, starts with getting good evidence and then looking at that. And that's why I think we really do need to demand high-quality evidence before we spend a lot of money.
And of course, the chair has the last word, so we'll go to Jeff next.
Yeah, I'm going to agree with Rita and Paul. It's really bothersome to have one study. We have what we have, but it doesn't make me very happy. And I wonder if, what Rita said is a good point. I mean, we've got all these, fancy, expensive devices. If you really want to treat heart failure properly, control blood pressure. It's way up front, and so we're kind of always dealing with it after the fact. This is a blood pressure problem, and if we did better at blood pressure control, we'd have a lot less of this. So it's really is a failure of the system that we have to come up with these things after the fact. Just something to think about is that we've got an opportunity to prevent, and if we could be more effective at it.
I would echo a lot of what's been said, and I also think this time more than others have struggled with what I alluded to earlier, is that we've got single studies that look promising, but you wish you had more, and then start to hear, oh, well, here's our experience now that this is out there and we're using it, which sounds far more compelling. How do we then either require better studies up front or collect some of this anecdote in a systematic way so that then we get some better guidance a year later as to who this works in, who it doesn't work in, so that we can continue to refine and not continue to throw money at something when maybe there's an opportunity to be smarter about who actually gets something. My sense is that the longer anything is out there, the more people it's used in, the indication creeps over time, and I think we need something that actually allows us to be more discriminating over time, and we don't get that.
Bob?
I found the vote on Entresto to be more straightforward, the one on CardioMEMS to be much more difficult for me. As a member of the old CTAF panel, I found life to be much more simple. It either worked or it didn't. What was the scientific evidence? But quite frankly, it didn't relate as well to the real world that I lived in. So I appreciate the discussion of value, as difficult as it is.
Other Bob?
Other Bob, I like that one. I kind of wrote one out here because I get lost on some of these sometime. I'd like to really kind of just touch briefly on one of the last things that you threw out here, Jed, or tried to get out to, is contract-based negotiations and pricing and things. One of the ideas that we keep throwing around is the word value. I'll hit that at the end here, but the folks that we always have on the panel, the payers, the providers, the manufacturers, always seem like smart people, and they're very nice, and I get along with them just fine. They're totally human beings. But nobody out there in the rest of the world thinks there's any sanity going on in the negotiations between those three groups, much less everybody else involved. I'm always taken aback by the reaction of the medical professionals in this room when we have a patient actually bring the story home of whatever one thing it is. That's not what we actually tell a bunch of patient advocates to do on the research side of things, but it's very useful in these kind of forums. And it just highlights that the real reality is we're not actually interested in value, we're interested in results, because that's what we all actually want that patient to be able to achieve. And so we need to be really careful when we're talking about value, when we really are trying to get toward results. And that, I hope, goes back slightly to the contract, negotiation, the pricing for performance kind of thing, because we do have to change the system somewhere along the way here, and clearly what we've got isn't really working right there. So,
thanks, Bob. Alex?
I'll try and say something different, though I agree with a lot of what's been said. We have these meetings every 4 months, and we'll say things like, evidence is mediocre, incredibly expensive. Evidence is pretty good, incredibly expensive. Evidence isn't very good, incredibly expensive. And we talk about, how the system only has so much room to absorb the new costs. but we talk about that incrementally, every one meeting at a time. And yet there's this, we meet 3 times a year, and then there's other meeting across the country, discuss another, group of drugs, devices. There's just this rising feeling of dread that there's, based on what we're discussing here and what's in the pipeline, that for any one of these could absorb just a huge proportion of that wiggle room that's in the system to absorb the cost of these drugs and devices. So, yeah.
We're left with a rising sense of dread. Thank you, Alex.
And the solution is?
Mr. Chair.
Last word.
Yes.
I guess I'm the bleeding heart in this group. I was the guy that voted high on almost everything. And this may be because of my career as a cardiac surgeon. I come back to the context that cardiovascular disease is still the leading cause of mortality and morbidity in this country. It's a very big deal. And the scourge of managing these patients is heart failure. We can treat angina, we can treat a lot of other things, but when the muscle starts to fail, that's the end of the road. And it's been frustrating, and it's disabling to patients. It's a terrible thing when you can't catch your breath, and it's very expensive, and it's a major cause of hospital expenses. We always plead for better studies. We've got 2 of them here. We've got, our CTs that, no study is perfect, but both studies seem to show improvement in every measurable outcome. So I guess I was more accepting that these were pretty good studies. And CardioMEMS, when you look at a surgical procedure or a device, this is very tough to randomize. You need a sham procedure. This is beautiful, where all of them got the device, and then you start getting data just from one arm of the study. Brilliant. So I was impressed with that. What to do? There's 2, I think people on the left would say we need more regulation, more top-down influence on how these technologies are utilized. I think a conservative would say, let's let the market forces play out. The market forces will play out in part based on what we did here today. We will have an influence, and if we find that one of these technologies is not high value, that will play out in the way the market works. So I'm very, very sanguine and very upbeat about what happened here today. I want to thank everybody for their participation. I think it was great.
Thank you, Mr. Chair. I get to issue some final remarks. I was really quite intrigued by the fact that this was the first meeting that I'm aware of where we considered a drug and a device for the same medical condition. And there are obvious huge differences in how we can either contract for or follow the results of drugs and devices. Glenn was talking about they're following 85 million lives, and they can do huge volume negotiations with manufacturers and by implication drive very significant discounts. And yet 2 hospitals that are leaders in cardiac care and implanting these devices seemingly are negotiating on their own. So the difference in the way the market plays out for these devices and perhaps what discounts are available stands out as a possible issue for action. I'm also intrigued that we didn't really get a chance to have the much broader discussion of the natural history of congestive heart failure, and are we really impacting it? Are we arresting the progression of class 2 to 3 to 4? Are we increasing the pool of patients who are going to get even more advanced heart failure therapies and have more patients on our cardiac transplant waiting lists then with no hearts to provide? And it goes to the point that Jeff raised, which is that we have to go upstream. We have to take the population preventive and proactive approach to try to prevent people from ending up with heart failure to begin with, in addition to being able to rescue them from the jaws of death once they have this life-threatening condition. So I think, as many have pointed out, these are the discussions that are yet a prelude to our next set of discussions in the fall and with CPAC in the, when's the next one, the winter. And I thank you all for your participation and active sharing of your thoughts. I very much thank our clinical experts and our manufacturer and health plan representatives. Thank you all for attending.
Meeting adjourned.